Anticoagulation Principles, Warfarin, Part 3, Dosing Warfarin. Now let's move on to Part 3, How to Dose Warfarin. As a reminder, I'll be using the ACCP guidelines from 2008 and 2012, which will provide evidence-based data for my lecture. Remember, it is considered the gold standard. Let's first talk about two lab values that are used to monitor warfarin, the ProTime and the INR. Prothrombin, or ProTime, was previously the most common test used to monitor warfarin therapy. A ProTime test measures how long it takes for a clot to form in a blood sample. The ProTime responds to a reduction of 3 of the 4 vitamin K-dependent clotting factors, 2, 7, and 10. The ProTime assay is performed by adding calcium and thromboplastin to citrated plasma. However, a shortcoming of using the ProTime was that results varied between different labs due to the use of different thromboplastin agents. This resulted in ProTime values differing from one lab to another lab. The ProTime needed to be standardized so a given sample's results could be reproduced at different labs. A calibration model called the INR is now used to standardize reporting by converting the ProTime ratio measured with the local thromboplastin into an INR, which is calculated as follows. The INR is equal to the patient's ProTime divided by the mean normal ProTime to the ISI power. The ISI reflects the responsiveness of a given thromboplastin to the reduction of the vitamin K-dependent coagulation factors compared to the primary World Health Organization international reference preparations. The lower the ISI value, the more sensitive the thromboplastin reagent is. So what is the optimal therapeutic range for patients on warfarin? That is, what are the INR goals? For patients on warfarin, what should the optimal therapeutic INR target be? For most patients taking warfarin, a therapeutic INR range of 2.0 to 3.0 with a target of 2.5 is recommended. This table shows a list of warfarin indications, and as you can see, the majority of indications has an INR goal between 2.0 and 3.0. For mechanical prosthetic valves, primarily in the mitral area, the INR target is a little higher, between 2.5 and 3.5. Warfarin does not possess a predictable dose-response relationship. Fluctuations in the INR and variation in dosage may occur because of many reasons. It could be due to patient-specific response, due to genetics or disease states, pharmacokinetic factors such as warfarin absorption and metabolism, drug-drug interactions, vitamin K intake, accuracy of INR testing, and patient noncompliance. After decades of use, clinicians have realized that there is no magic formula to dose warfarin in patients. Warfarin dosing is largely an empiric practice. This means that after a dose is given, we rely on the behavior of the lab values to guide us to determine the next dose. We also are equipped with the knowledge that any changes in warfarin's effects to show up will be delayed by 2 or 3 days, based on its unique mechanism of action. Warfarin is available in a variety of colors, each representing a specific dosage. It's good for clinicians to be familiar with these colors, as patients taking warfarin might refer to their medication for thinning the blood as a green pill. Of note, as of 2020, the Coumadin brand is no longer available. A fun mnemonic can be used by students and clinicians to remember the warfarin colors by remembering the phrase, "Please let Granny Brown bring peaches to your wedding." Also of note is that the white 10 mg dose is the only strength that does not contain dyes for those sensitive to them. Let's first talk about how to determine the initial dose. Baseline laboratory measurements prior to warfarin therapy should include the INR, CBC, and platelets. What should the initial dose for hospitalized patients be? For hospitalized patients, the initiation of oral anticoagulation should begin with warfarin doses between 5 and 10 milligrams for the first 1 or 2 days for most individuals, with subsequent dosing based on the INR response. Give a fixed initial dose of warfarin for the first 2 days of therapy, then obtain an INR the next morning to guide the selection of a maintenance dose. Following the administration of warfarin, an initial effect on the INR usually occurs within the first 2 or 3 days, depending on the dose administered. A warfarin loading dose that is greater than 15 to 20 milligrams is not recommended. What should the initial dose in debilitated patients be? A starting dose of less than or equal to 5 milligrams is recommended for the elderly, greater than 65 years old, in patients who are debilitated, malnourished, have heart failure, or have liver disease, or having had a recent major surgery, and in patients who are taking medications known to increase the sensitivity of warfarin. What about the initial dose for outpatients? For patients starting warfarin as outpatients who are sufficiently healthy, some clinicians prefer to use a larger starting dose, that is 7.5 to 10 milligrams. Kovacs et al. Found that outpatients who had been treated for venous thromboembolism, an initial 10 milligram dose for the first 2 days of therapy compared to a 5 milligram dose resulted in a more rapid achievement of a therapeutic INR, without a difference in rates of excessive anticoagulation. Patients previously on warfarin. For patients taking warfarin prior to admission, it is important to know that the warfarin requirements in their healthy state most likely will change once the patient is hospitalized. Warfarin doses taken 2 to 3 days prior to admission will have the most prominent effect on the current day's INR. So after the initial dose is given, let's talk about how we make daily dose adjustments. Here is where INR monitoring becomes very important. INR monitoring should be started after the initial 2 or 3 doses of oral anticoagulation therapy. INR should be obtained daily. Once the INR is in the desired range for 2 or more consecutive days, the frequency of INR monitoring may be reduced. So how do we make the initial dose adjustment? The INR response after 2 to 3 days can be used to predict the maintenance dose. If the INR rapidly increases, the patient may be a slow metabolizer, so use a lower maintenance dose. However, if the INR response is slow, use a slightly higher maintenance dose. To determine the maintenance doses of warfarin for a patient, clinicians often utilize warfarin dosage algorithms to figure out daily dosages until the INR stabilizes. These algorithms are readily available on the internet. Some are more aggressive than others, so when selecting the proper algorithm, use considerable clinical judgment when deciding and tailor your algorithm to the specific patient population for your individual institution. Here is a typical example of one algorithm. For a new start, 5 milligrams or less should be used as the starting dose, as we previously discussed. If the patient was taking warfarin at home, continue the same dose as long as the INR is not at a toxic level. On day number 2, 5 milligrams is continued in this algorithm if the INR is below goal. This algorithm is rather conservative in that dosage is reduced if the INR is within goal on day number 2. Hold the dose if the INR is above 3. Actions for day number 3 is identical to day number 2. By day number 4, higher doses are given if the INR reaches goal. Finally, by day number 6, higher doses are used if the goal is subtherapeutic. Again, this is a more conservative algorithm. This is an example of an algorithm used to adjust doses once the patient is maintained under specific daily dosage. Small percentage changes are used here if the INR is not therapeutic. Drastic adjustments are not used. Here are some rules of thumb regarding dose adjustments. Most patients require a warfarin dose, usually somewhere between 3 to 6 milligrams per day, with an average maintenance dose of 5 milligrams per day. The INR is usually not changed by the most recent dose. And only small maintenance dose adjustments are recommended, approximately 10 or 20% of the total weekly dose to increase or decrease. Here are some more rules to consider. In general, when the warfarin dose is held, the higher the warfarin dose, the faster the INR will drop. The INR will drop by 50% approximately every 48 hours. Men require more warfarin than women, about 4.5 milligrams more per week. Patients heavier than 234 pounds require larger warfarin maintenance doses, and people who are small tend to have high INRs. Management of subtherapeutic INRs. For patients on maintenance doses of warfarin who have subtherapeutic INRs, there are no specific studies examining the optimal method of correction. Since the average daily risk of thrombosis for most indications is quite small, patients do not generally need to be covered with a rapidly acting anticoagulant such as heparin or low molecular weight heparin. Rather, the weekly cumulative dose of warfarin is usually increased by 10 to 20%, and more frequent monitoring is instituted until the INR is stable. In some cases, patients may be given a one-time larger dose. What do we do when the INR is elevated? Management of elevated INRs. The choice of approach when the INR is elevated is based largely on the level of the INR, the potential risk of bleeding, the presence of active bleeding, and clinical judgment. Patients with minimally elevated INRs and no bleeding can be managed by either more frequent monitoring without a dose change, with the expectation that the INR will return to therapeutic levels without a dosage change, adjusting the dose down in increments of 5 to 20% based on the cumulative weekly dose, or by stopping warfarin for a day or more, reducing the weekly dose, and monitoring more frequently. In general, the higher the warfarin dose, the faster the INR will drop when the dose is held. If the patient is taking 6 milligrams or higher, it's best to hold for one dose before checking. For 3 milligrams or lower, rechecking in 48 hours is sufficient. Here's a table summarizing what action to take if the INR is elevated and there is no bleeding. This information is taken straight from the current ACCP guidelines. We will review each section separately. What do we do if the INR is above the therapeutic range but less than 5.0 and with no significant bleeding? If the INR is only minimally above the therapeutic range, no dose reduction may be required. We can also lower the dose or omit the dose and monitor the INR more frequently. Resume the therapy at a lower dose when the INR is at a therapeutic level. What do we do if the INR is greater than or equal to 5 but less than 9 and there's no significant bleeding and rapid reversal for surgery is not required? The action is to omit the next 1 or 2 doses and monitor the INR more frequently. Resume therapy at a lower dose when the INR is at a therapeutic level. If there's an increased risk of bleeding, omit a dose and administer vitamin K 1 to 2.5 milligrams orally. If the INR is greater than or equal to 5 but less than 9 and there's no significant bleeding, but rapid reversal is required for urgent surgery, give vitamin K less than or equal to 5 milligrams orally with the expectation that a reduction of the INR will occur in 24 hours. If the INR is still high Additional vitamin K, 1 to 2 milligrams orally, can be given. If the INR is greater than or equal to 9.0 and there's no significant bleeding, hold the warfarin, administer a higher dose of vitamin K, 2.5 to 5 milligrams orally, with the expectation that the INR will be reduced substantially in 24 to 48 hours. Use additional vitamin K if needed, monitor the levels more frequently, and resume therapy at a lower dose when the INR reaches therapeutic levels. Let's discuss a few important points about the use of vitamin K. High doses of vitamin K greater than 5 milligrams, though effective, may lower the INR more than is necessary and may lead to warfarin resistance for a week or more, since it will accumulate in the liver. When vitamin K is used, it should be administered in a dose that will quickly lower the INR into a safe range, not lower the INR into a subtherapeutic range, causing resistance once warfarin is reinstated, and not expose the patient to the risk of anaphylaxis. IV administration of vitamin K faster than 1 milligram per minute causes a greater risk of anaphylaxis. The response to vitamin K administered subcutaneously is less predictable compared to oral vitamin K and is sometimes delayed. In patients with mild to moderately elevated INRs without major bleeding, vitamin K should be administered orally rather than subcutaneously. When the INR is between 5 and 9, a vitamin K dose range of 1 to 2.5 milligrams is effective. To correct INRs of greater than 9, larger doses of vitamin K, such as 5 milligrams, are required. The oral form of vitamin K is available only as a 5 milligram tablet called Mephyton. For vitamin K doses less than 5 milligrams, that is, for example, 2.5, 2, or 1 milligram, cutting the small tablet into a portion will lead to inaccurate dosage administration. Therefore, it is recommended that smaller doses be administered as an oral solution. This solution can be easily and quickly compounded extemporaneously by the pharmacy by diluting the injectable form of vitamin K. Using a filter needle, take vitamin K 10 mg per ml ampule and draw up 1 ml, which is equal to 10 milligrams, into a syringe. Replace the filter needle with a regular needle. Draw up 9 ml of sterile water for injection for a total volume of 10 ml. Transfer this solution to an amber glass bottle. Label the container phytonadione oral solution, concentration 1 mg per ml, for oral use only. Store at room temperature with a 3-month expiration date, and dispense the doses in amber plastic oral syringes with a beyond use date of 24 hours. If the patient is NPO, vitamin K can be administered as an IV piggyback in 50 ml of NS over 20 to 30 minutes. If the patient has a high risk for bleeding, or if bleeding has already developed, patients can be managed by one or more of the following: omitting one or more doses, more frequent monitoring, and actively intervening to lower the INR more rapidly by using vitamin K, fresh frozen plasma, and 4-factor prothrombin concentrates. We will be discussing this more in depth in the next lecture. Overlapping heparin when starting warfarin. When starting warfarin and an immediate rapid anticoagulant effect is needed, heparin should be administered concurrently. Remember, warfarin has a delayed onset of action of 2 to 3 days. Heparin's administration should be overlapped with warfarin for at least 4 to 5 days until the INR is in the therapeutic range for at least 2 days, 2 measurements at least 24 hours apart. What is bridging therapy? Bridge therapy is using unfractionated heparin or low molecular weight heparin to maintain a person's anticoagulation status when warfarin must be temporarily stopped. Patients who are receiving long-term anticoagulant therapy may need to temporarily stop warfarin for invasive procedures. In these cases, heparin may be used to bridge the time the patient is off warfarin. No product has FDA approval for bridge therapy. There are no consensus on definitions or strategies, and no randomized controlled trials comparing various regimens. Let's go over a few warfarin case examples. Warfarin case number 1. LE was admitted on 2/18 with heart failure. The patient is status post AICD and CABG and has a history of lumbar spine surgery. She's 87 years old, 5 foot 4 inches, 65 kilograms. She's been taking warfarin 3 milligrams daily prior to admission, her last dose on 2/17. She's on warfarin because of a mechanical heart valve with an INR goal of 2.5 to 3.5. And she's continuing her home medication, which is amiodarone. You can see on this grid that on Tuesday, February 18th, her INR was 2.9, and the 3 milligram dose of warfarin was continued from the February 18th through February 22nd. On Sunday, February 23rd, the INR was 4.5, and the warfarin was placed on hold. Question: what could have been done to avert the elevated INR of 4.5? The answer is pretty simple. The INR should have been checked sooner. Even though the INR was therapeutic on admission, the 3 milligram dose should not have been continued without checking the INR again. You can assume with heart failure and with hospitalization that the INR is going to continue to be the same value. Case number 2. ML is admitted on 2/23 with a rule out of acute coronary syndrome, status post CABG, AFib with rapid ventricular response, and chronic kidney disease on hemodialysis. She's a 71-year-old female, 5 foot, 54 kilograms. She's been taking warfarin at home at a dose of 5 milligrams a day. She's on warfarin for AFib prophylaxis with an INR goal of 2 to 3. Her baseline INR was 1.1 on admission. A new order for amiodarone was started on admission. So take a look at the grid of ML's course. On Sunday, February 23rd, her INR was 1.1 with a dose of 5 milligrams continued from her home dosage. A new order for amiodarone was started on 2/23. On Monday, no INR was drawn, 5 milligrams was continued. On Tuesday, February 25th, the INR went up to 1.6 and another 5 milligram dose was given. On Wednesday, the 26th, the INR went up to 3.1 and a reduced dose of 2.5 milligrams of warfarin was given. On February 27th, the INR went up even further to 3.4 and warfarin was placed on hold for 2 days. When the INR reached or decreased down to 2.4, a 2 milligram dose was given and continued on. Question: describe the patient's treatment course. Could anything have been done differently? This is a classic example of amidarone's effect on warfarin. Possibly on February 26th, 2.5 milligram dose was given with an INR jumping up to 3.1. Maybe the 2.5 milligrams should not have been given. However, in this patient, everything went okay with a reduced dose of 2.5 and warfarin placed on hold for 2 days. The INR did not go above 5.0. Case number 3. PL is admitted on January 19th with AFib with rapid ventricular response, a history of multiple myeloma, and end-stage renal disease. She's an 85-year-old female, 72 kilograms. She's been taking warfarin at home per her physician, but no record of warfarin was given on med reconciliation. She's on warfarin for AFib prophylaxis with an INR goal of 2 to 3. And Levaquin was started on January 22nd which was a few days into her hospitalization. Taking a look at the grid, on Sunday, January 19th, her admitting INR was 1.7, and a dose of warfarin of 5 milligrams was given. The next day, the INR did not change, and so 7 milligrams was given. The next day, the INR went up to 2.1, and 5 milligrams of warfarin was given. The following day, on January 22nd, the INR went up to 2.6, and the dosage of warfarin went down to 4 milligrams. On that day, Levaquin was started on the patient. On Thursday, the 23rd, the INR jumped up to 3.8, and a dose of 4 milligrams of warfarin was given. The following day, the INR continued to go up and went up to 4.2. The dose of warfarin was held, and vitamin K 2.5 milligrams orally was given. The INR continued to go up to 3.1, then decreased down to 1.9, where at that time warfarin 3 milligram dose was given. Question: describe the patient's treatment course. Should anything have been done differently? Comment on the use of vitamin K in this scenario. The patient's first 3 doses of warfarin should have been consistent. You can see the impact of Levaquin as the INR went from 2.6 to 4.2. On January 23rd, when the INR went up to 3.8, the 4 milligram of warfarin should not have been given. Also, it was not necessary to give the vitamin K when the INR went up to 4.2. Rather, just hold the dose and let the INR drop to therapeutic. In Part 3, we define INR and how it is used to monitor warfarin. We outlined how to select the initial warfarin dose and how to adjust the dose. We described how to manage subtherapeutic and elevated INRs, and we defined bridging therapy and when to use it. In Part 4 of this 4-part series on warfarin anticoagulation, we'll list the adverse effects of warfarin and patient risk factors for bleeding. We'll summarize antiphospholipid antibody syndrome. We'll describe Kcentra, what dose to use and how to prepare it, and we'll go over what type of counseling information should be provided to a patient on warfarin. So stay tuned. Thanks for tuning in to watch this installment of the PharmEasy Tutor. I hope you learned something that you could use at school or in practice. If you'd like to continue to see more of these types of tutorials on YouTube, please make sure to click on the subscribe button below to change it from red to gray. Also, if you like this video, I would appreciate it if you can click on the thumbs up icon below to change the color to blue. If you have any comments or questions, please feel free to add them in the comments section below, or share this site with someone else. Stay tuned to the PharmEasy Tutor channel for more lectures in the upcoming weeks. So until next time, remember to take it easy.